Good morning. Welcome to Chapter 19, where we're going to be talking about a lot of different disorders. We're going to be talking about anemia, iron deficiency, sickle cell anemia, cancer, and not only the pathophys, but the nursing assessments and interventions that you should be doing to help these pediatric patients. We're going to be talking about nursing care plans, caregiver education, and as well as immunodeficiency disorders and stem cell transplants. So we are going to break up Chapter 19 into 3 different disorders. We have hematologic disorders, we have immunologic disorders, and we have neoplastic disorders. When you start looking at those as separate categories, it should really help. So first off, iron deficiency. So when we start looking at hematological disorders, hematopoiesis is a process through which the bone marrow produces blood cells and platelets, and that's different than erythropoiesis, which is the production of red blood cells. If you remember, your red blood cells increase a patient's hemoglobin and oxygen capacity. Your lifespan of a red blood cell is only 120 days. And so after that, you have to remember that the phagocytes in the spleen and liver will hemolyze them and basically destroy them. If you remember, those phagocytes are responsible. I kind of always think about it as a little Pac-Man. It eats stuff and destroys it. And so that red blood cell really is only good for that 120 days. And you guys will see that number, not only on exams, but as well as on your NCLEX, because it's really important. A lot of your patients, whether peds or geriatrics, have blood disorders. So iron deficiency anemia, this is the most common one. And this occurs when there are not enough healthy red blood cells to carry oxygen to the body's tissue. It really is a dietary deficiency, and we see this a lot about right after the 1-year age, and that's when kids are given bottles of milk. Your babies and infants are used to taking those bottles. That sucking reflex and mechanism is a safety to them. It's a soothing, and so it's real easy for mom and dad or caregiver to put milk in that bottle, and the infant likes it. And a lot of times they'll get full on the milk in the bottles and not want to eat. And that's where we start seeing it. I had a cheat sheet when I was going through school that kind of told me the differences between the anemias. I recommend doing that because they can be a little bit confusing. But just remember, your iron deficiency anemia is the most common, but it is a microcytic anemia, so they have small, pale red blood cells and depleted iron stores. And so this also will cause a decrease in bone marrow erythropoiesis. So these kiddos should have a screening hemoglobin at 12 months at their healthy child visit, which is why it's so important that we educate caregivers to take their kids to their pediatricians or primary care for the well child visit and not just when the child is sick. Kids with iron deficiency anemia can have irritability, anorexia, tachycardia, systolic murmur, brittle and concave nails, poor muscle tone, prone to infection, and some people can say they almost look porcelain-like. And what that means is basically their skin just looks translucent, or you can almost see through it. So you can see those blood vessels. And I've seen some bellies on a kid where you could almost see, some of their organs as well. Granted, they're going to be really bad if you can see that much, but it can happen. They can have delayed growth. They can have decreased serum concentration of proteins, albumin, gamma globulin, and transferrin. They can have some cognitive delay. And these kiddos, you're going to want to do a CBC with red blood cell indexes. And on those RBC indexes, you can see normal, borderline, or you can even see moderately reduced. But just remember, they can be normal or borderline. The red blood cells will be small in size. The serum iron is going to be low. You're going to get a serum ferritin on them. You're going to have a TIBC, and then you're going to have erythropoietin level, a retic count. And again, I literally, when I was in school, just had a little chart back then, you know, because we didn't have cell phones. That sounds terrible. I'm old. I can remember when I got my first BlackBerry. But get it in one of your notes somewhere and literally have the anemias, which is microcytic, macrocytic, and normocytic, and then just go right down. And it really helps when you have that TIBC, the ferritin, and the iron, which is which. And I'll try to see if I can find a good chart and send to you because I do think it's important. Nursing interventions, of course, diet. You're going to have them getting that kid off the bottle with milk if they're still on it. You're going to be giving them a vitamin. You can do a liquid dosage of iron. Just remember, this can really stain the teeth. So if they're taking liquid iron, they need to be given it through a straw so it doesn't stain those teeth. If you're going to be given an injection, which they do have one, it's imiferon. And just remember for that injection, you do a Z-track injection. If you don't know what a Z-track, look it up. But basically, let's say you have your hip where you're going to give it. You pull the skin taut. Let me get my hand up here where the camera can see it. And when you put the needle in, then you let the skin go. And you're going to leave that needle in there for just a few minutes. Or not a few minutes, but, you know, 30 seconds to make sure all of the liquid is out of there to stop dripping. And then you're going to take it out. You don't, when you let that skin go, if you think about how the skin is in there, it kind of helps seal that up so that that iron doesn't get in the sub-Q tissue because it can cause some scarring. If it's a baby that is still on formula, you want to make sure that they're getting iron fortified formula. And if they're on an iron fortified formula, usually they don't need iron supplementation. And then this little chart I have on here is some of the different ones that we can give them. And we have ferric gluconate, which is a parental iron salt. And this is only given over the age of 6, and they're going to get 1.5 milligram per kilogram per dose for 8 doses only. And this is the one that is an iron deficiency associated with hemodialysis. We have ferrous fumarate, which is an oral iron salt, and it's 4 to 6 milligrams a kilogram a day, and that is given for severe iron deficiency. We have folic acid, which this is the first one that I typically see people in or given, and that, remember, is a water soluble B complex vitamin. But you can also, you can give it PO, but you can also give folic acid IV, IM, sub-Q, and they typically give 0.1 to 0.4 milligrams a day. And then iron dextron, which is a parental iron salt. And so these are given IM or IV, and if it's a small child, 5 to 10 kilograms, 25 milligrams a day. If they're over 10 kilograms, then you give 50. You do need to make sure, though, you have epinephrine available in all cases in case of anaphylaxis. So, of course, they're going to start out slow and get higher. And typically, like I said, folic acid is the first one. Acquired thrombocytopenia. This is where the platelet counts decrease because of an infection. A lot of times it's due to like Rocky Mountain spotted fever, Colorado tick fever, malaria, and sometimes can be bacteria or sepsis. You can see drug or chemical exposures being a factor. And the good news is, though, when it's exposure and you remove those, whatever is causing it, it typically will recover on its own. The bad news is if it's from sepsis or some of the tick fevers, you do have to treat it. You do want to check for any recent spontaneous bleeding, such as, have they had bloody noses? If they're, brushing teeth, are their gums bleeding? Do they have any blood in the feces? Do they have any scabs all over? Have they been coughing or vomiting blood? Your petechiae, which kind of shows on the back of this kid, but you often see them over bony prominences. And so what that means is, where the bones are close to the surface. So like, on their shoulder, the top of their humerus, their wrists, hips, but they can be anywhere. You also want to assess them for any recent exposure to chemicals, insecticides, paint, gasoline, kerosene, lawn, like your Roundup to kill out the weeds. You want to make sure, have they been bit by a tick or a mosquito, that they've got some funky, rash. Have they had any recent viruses? Have they had any recent bacterial infections? Because we do see petechiae a lot of times in sepsis. Have they had any recent exposure to measles, mumps, rubella, chickenpox? And so it's really important to get that baseline comprehensive assessment and getting the caregivers involved in, trying to get a history. So you're going to do a CBC because you're specifically looking for platelet counts, and these platelet counts are typically decreased. Nursing interventions, you have to remember it's a bleeding precaution, so you're going to do very soft oral care. You're going to be monitoring the stools. You're going to be monitoring for nosebleeds. You're going to avoid intramuscular injections that can cause the skin to bleed, or suctioning. Thinking any kind of trauma to the mucous membranes can cause bleeding. You're going to avoid use of any aspirin or Motrin or anything that has a salicylate in it, because these can interfere with platelet aggregations. Your NSAIDs, which, like I said, Motrin, that can also interfere. You're going to administer steroids to increase platelet production and decrease the vascular fragility. And you're going to modify age-appropriate activities to avoid injuries. So if this is a 7 or 8-year-old boy and he's in Mighty Mite football, you're going to tell him, until he gets the all clear, he needs to not be in football. So just make sure they're doing age-appropriate. When you have a baby, or I say baby, but a toddler that's, 2 or 3 years old, they're falling all the time. So you really have to kind of be careful with that. And you may really need to collaborate with a physical therapist. They may, depending on how severe it is, they may have some prolonged time in bed without activity. So again, that physical therapist can kind of help you determine what are some appropriate activities. And you want to encourage a positive self-image and self-care. You want to teach the caregivers about the side effects of the steroids. Remember, they can get fluid accumulation with those steroids, so you can have the moon face. You can get a moon face typically fast. You don't see the humpback unless they're on it for long term. You can get some pedal edema. Of course, it causes irritability. It causes hyperactivity in a lot of kids because it gives them energy. And then you've got this kid that's supposed to be in bed, so it's very difficult. They don't want to sleep at night, so it's a little difficult. You want to give the steroids with food. They typically do taste pretty bad, even if they're big enough for a pill. So you want to make sure they have something to drink afterwards to get that taste out of their mouth. You want to limit their sodium intake because, again, they're retaining fluid and you want them to pee out that fluid. And you just want to be supportive. It's hard, and hopefully, you know, that this goes away pretty quickly. Sickle cell. Most of you all know this is a great picture of sickle cell. I think sickle cell is not talked about enough, but so on the left-hand side there, your normal blood cell is nice and round. And then on the right side is the abnormal hemoglobin or sickled red blood cell. So when you see these, and you can see the hemoglobin inside that red blood cell are almost like little squares instead of round. See on the left how the hemoglobin inside the red blood cell is round? And so when you think these things are supposed to pass through everything very nicely, well, in a sickle cell crisis, think of how these are going to clump up. And so it is extremely painful. But basically, so yeah, the red blood cell and the hemoglobin, they basically get deformed into this crescent shape, and they can cause delayed growth, delayed puberty, acute and chronic pulmonary dysfunction, stroke. Think about if this goes to the head, if they're clumping together. It can cause aseptic necrosis of the hips and shoulders. Again, think if it's getting in joints and it's going to prevent normal blood flow. Horrible pain when they're in crisis, and they can have some psychosocial dysfunctions. When both parents have the sickle cell trait, there's a 1 in 4 chance with each pregnancy that the child will have sickle cell disease, and about 1 to 13 African American babies are born with sickle cell trait. They are typically about asymptomatic until they're about 4 to 6 months old, and that's due to the presence of the fetal hemoglobin from mom. This resists sickling and suppresses the symptoms. Then, you know, and remember we talked about how red blood cells only live 120 days. So as these start getting replaced, sickle hemoglobin and sickle cells replace the fetal hemoglobin at 5 months old. The sickled red blood cells die early, and so there's not enough red blood cells to carry oxygen in the body. As the disease worsens over time, sickle cells do not flow smoothly through the vessels. And this can cause, remember I said sickle cell crisis, it's also a vaso-occlusive crisis. So really you get obstruction of the blood flow causing, you know, tissue hypoxia and necrosis. So that tissue is dying. Very painful, and usually it's a symmetrical infarct in the bones of the hands and feet, and very painful swelling of soft tissue. You can have an acute chest syndrome where you have a new pulmonary infiltrate because they're having, you know, one of those sickling where the cells are sticking together go to the lungs, and they have chest pain, fever, cough, tachypnea, wheezing, hypoxia. You can see a crisis in the loss of spleen function from frequent infarcts, and you can have pooling of a large amount of blood causing spleen enlargement. They can have a stroke because they have blockage of the blood vessels in the brain with impaired neurofunction, severe headaches, twitching of the face, legs, arms, seizures, change in speech, weakness in the hands, feet, legs, abnormal behavior. So you really want to assess for psychological adjustment, including both emotional and behavioral problems related to long periods of hospitalizations, as well as think how emotional it would be to be a child and be in chronic pain. Diagnostic testing is a sickle turbidity test, which is called a sickle dex, and that's a fingerstick blood, and you can get those results in about 3 minutes, and that tells whether the hemoglobin S is present. Hemoglobin electrophoresis is accurate and rapid, and that quantifies the percentage of various types of hemoglobin S and hemoglobin A. Your interventions, you're going to give anesthesia because they are hurting, especially during the vaso-occlusion or sickle cell crises. Pain distraction techniques, including self-hypnosis, get their mind on something else, get them focused on something else. Activity, rest cycling for periods of activity intolerance, hydration, IV therapy, oral fluids, antibiotics for any infection treatment. It has been found that penicillin prophylaxis significantly reduces the risk for pneumococcal infection at about 2 months of age. Hydroxyurea is cytotoxic and is used to reduce the frequency of painful crises and reduce the need for blood transfusions in patients that have recurrent or moderate to severe crises. Metabolic acidosis treatment with IV electrolyte replacement, of course, physical therapy, cognitive behavioral therapy that helps with controlled breathing, positive self-talk, behavioral rehearsal, hand holding, humor, music and memory reframing. Sometimes they do have to have a splenectomy, but they typically only do that for life-saving measures. They can have hemopoietic stem cell transplantation. And remember, if it's a hemopoietic stem cell transplant, that's from their cells, their own stem cells. And then you're also going to want to be monitoring for acute chest syndrome, for chest, back, abdominal pain, fever, congestion, shortness of breath, fast respirations, sternal retractions, decreased oxygen sats of less than 92%. And you're going to want to do the administer the blood transfusions as ordered. For caregiver education, you're going to be giving resources for the family, genetic counseling, teaching the caregiver signs and symptoms of infection, when to be checked and get further treatment. They need to be educated. They may need prophylactic penicillin before dental procedures. They need education on HIV, pneumococcal and meningococcal organisms. So lots and lots of things to go through with the patient on this and their caregiver. It is, anytime you're dealing with the patient, it's not just the patient. The whole family needs to be brought in and brought into the plan of care. Aplastic anemia. There on that left side, you can see the normal blood cells, and on the right side, you can see aplastic anemia cells. But basically, the pathophys is a deficiency of the formation of blood elements. Pancytopenia is decreased. Leukocytes, platelets, and erythrocytes. You're going to have damage to these blood cell types. Assessing, you're going to be checking for fatigue, history of illness or injuries that are not healing. Diagnostic tests, they're going to have CBC with differential platelet counts to diagnose a specific type of anemia. Their retic count is going to show less mature red blood cells, and an increase in the percentage of retic count means that a release of red blood cells is occurring more rapidly than usual to try to compensate for the deficiency. Bone marrow aspiration confirms red blood marrow conversion to yellow fatty bone marrow. Nursing interventions, you're going to want to monitor immunosuppressive therapy. You're going to want to monitor blood transfusions and IV infusions, and you're going to want to try to decrease infections and teaching caregivers how to decrease the risk of infections, good hygiene. The pathophys of aplastic anemia, we've kind of already talked about. So this can be really damaging. Hemophilia is a deficiency of factor VIII. And so factor VIII is a substance produced by the liver that assists with thromboplastin formation and blood coagulation. The clotting factors are present, but in diminished capacity. the defective factor is unable to do its job in the clotting cascade, so the cascade is halted and the fibrin clot is unable to form, leading to uncontrolled bleeding when the injury occurs. Both hemophilia A and hemophilia B are inherited as X-linked recessive traits, which affects the males. So females are the carriers, but they don't have the disease. Assessment, you're going to check for history of bleeding, nosebleeds, bleeding around the gums, rectal bleeding, any bleeding in the mucosa membrane. Are they having hemarthrosis, so bleeding into the joint cavities of the knees, ankles, elbows? Do they have any bruising? Diagnostic testing, they're going to have a PTT, which is a partial thromboplastin time. This is going to be prolonged and indicating ineffective clotting factors except factor 7. They'll have a low level of factor 7 or 9 coagulant. And a lot of times these patients don't have any bleeding in the first year of life until the child starts to walk and fall. And then you start seeing a lot of abnormal bleeding and bruising. And a lot of times the first injury is actually bleeding from the oral mucosa. Nursing interventions, you're going to administer factor 8 from pooled plasma as prescribed by the physician. You're going to administer DDAVP, which is a synthetic form of vasopressin to increase plasma factor 8 in mild cases. They're going to have corticosteroids if they have any hematuria or any of that hemarthrosis, which is that bleeding into the joints, or synovitis. They're going to have NSAIDs for relieving pain, but remember your NSAIDs can interfere with platelet formation, so be careful with it. You do need to completely avoid aspirin in these kids. You want to avoid chronic use of codeine. You want to have supportive care with exercise and physical therapy, and it would be good to get a physical therapist involved in this. You want to talk about accident prevention and preventing injury in the environment, helmet use, activity restrictions. They're not going to be able to do contact sports. Again, providing soft toothbrushes and venipuncture. And if instead of drawing the blood, you can do a finger poke, that's always better. Occasionally, though, you just have to do the blood stick. You want to educate these parents that their kids need a medical alert tag. And they do have prophylaxis, periodic factor replacement of factor 8. And lots of resources from the National Hemophilia Foundation. So it's very important to get the family hooked up with them and to, see what additional resources that they offer. Lead poisoning, chronic ingestion or inhalation of materials containing lead. We don't see it as much as we used to now that they've started getting rid of the lead-based paint. A lot of the kids in the 80s and 90s was very common because they would, a little kid goes up and num 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 on the windowsill. And a lot of the older homes, the windowsills were closer to the ground where they could actually reach them. And they would have cracked or peeling paint. So that's why we do a lead test on these kids. Iron deficient anemia is characterized by what? Is it A, small pale red blood cells and decrease in bone marrow erythropoiesis, large pale red blood cells and dangerous increase in bone marrow erythropoiesis, platelet count decrease in spontaneous bleeding, platelet count increase? It is A. If you remember, we talked about small pale red blood cells, depleted iron stores, and so that does affect a decrease in bone marrow erythropoiesis. Acquired immunodeficiency syndrome. Remember, this develops from your HIV. So if you've noticed, we've switched over to the immunological disorders. Immunology is the mechanism which the body defends itself against infectious agents and foreign substances. Without the strong immune system, the body is unable to defend against HIV. And development of an antibody to HIV is the first step in determining HIV infection. The acquired immunodeficiency syndrome, or AIDS, develops from HIV. It's most commonly affecting children who are transmitted in utero from a mom who has HIV. Using preventative medicine during pregnancy can reduce the risk for HIV significantly. The meds that we have for HIV and AIDS nowadays are huge. In fact, they won't say they can cure it yet, but they have proven that a lot of the medications can give them a 0 viral count, and kids are not getting it in utero. So it's really huge. These medicines are still immensely and huge expensive. So you want to refer any child or family member with HIV or hepatitis, completely different, but hepatitis, to the local all right, on to oncology. So as you know, oncology is cancer, and these are a group of complex diseases with uncontrolled growth and spread of abnormal cells. Treatment for cancer varies according to the pathophys, the diagnosis, but remember, we can have treatments of chemo, surgery, radiation, bone marrow transplants, but it really does depend on what kind of cancer it is, where it's at, because not all cancers respond the same. A neoplasm is uncontrolled abnormal cell growth, and so the pathophys is a cell just continues to grow and grow and becomes a tumor. Tumors can be benign, which is non-cancerous. They can be malignant, which are cancer. Metastasis is the ability of the cancer cells to invade surrounding tissue or spread to other parts of the body. Causes of most cancer are, your book says unknown, but from personal experience, everything I've always been told in my schooling was causes of cancer are chronic irritation. So if you think about it, smoking irritates the esophagus, the trachea, the lungs. Chewing tobacco irritates the mouth. Think about also like your elderly that have the ill-fitting dentures that rubs. Any chronic irritation causes cancer. So it's always important to get those out. The some of the other theories can be that viruses, a specific kind of viruses, can cause cancer, and I'm not going to disagree with that, agree or disagree with that. I think that they could. I think we just need better research to follow up with that. You guys are going to learn in healthcare. We know so much, but there is still so much that we do not know. Think about all of the brain disorders and people that have these funky things that they honestly do not know. And so as a nurse, it's okay to say you don't know something. And you will often hear me say something I don't know. And I will tell you that's what makes me one of the best nurse practitioners you will ever meet, because I know what I know, but more importantly, I know what I don't know. And I always know where to look or who to ask. But when it comes to some of these medical disorders, there may not be any answers, so we do the best we can. Genetic and heredity conditions can cause unregulated genetic activity and tumor growth, especially like in Wilms tumor. So specifically in Wilms tumor, it's typically discovered by caregivers with a lump in the abdominal area when dressing or bathing a child. We see in adolescents, we see Hodgkin's lymphoma. So there, and osteosarcoma is another hereditary cancer. The good news is most of the hereditary cancers, not all, but most are pretty treatable and do have, and you know, cure is a realistic goal. Now, I am so sorry. I don't know how that happened, but going back to cancer, you know, it depends on where it's at, what kind of cancer it is, and to know what kind of cure you have. Brain tumors can arise from any cell in the cranium and are classified by their location. Neuroblastoma, which is the most common type, comes from the embryonic neural crest cells. In 70% of neuroblastoma cases, the cancer is discovered after it metastasizes, and usually that will metastasize to the head, neck, chest, or pelvis. Assessing these kiddos, you're going to see increased head size in infants due to the increased intracranial pressure. And I don't know about you guys, but I've had headaches before when I've had a really high fever, and it's horrible. So think about when the headaches from increased intracranial pressure. Another signs and symptoms are headaches on awakening, nausea, vomiting, uncontrolled. Monitor their pulse pressure, which is, if you remember, your pulse pressure is the difference between the systolic and the diastolic pressure. Pupils are sluggish, dilated, or unequal. They might have an unequal or a weak hand grasp. The testing is going to be an MRI. They may have a CT or an CT angiogram, but they do often have to do the MRI. They're going to have an EEG. They're going to have lumbar puncture, and they may have to have surgery. A PET scan is super important. A PET scan is a positron emission tomography scan. And what a PET scan does is it takes a CAT scan and puts the PET scan over it. And so it makes anywhere in the body that has tumor light up. The only downside to it is it can also, if you have a lot of inflammation, like for instance, if somebody has a really bad tendonitis, that could show up and it not be a tumor. But it's very helpful when looking for tumors. Remember, you're going to not lie to the child, but only tell them as much as they need to know. Let them know it's okay to cry, and you're going to make sure that they know what is going to happen. You're going to do a lot of distractions. You're going to let the caregiver be present as much as possible. Administer pain medicine, and remember that these kids are probably going to have chemo and radiation, and so you're going to, if they are, you're going to need to look at their mouth for open sores from stomatitis, because a lot of times that stomatitis can get pretty severe. You're going to monitor for seizures and changes in posturing. You're going to monitor for temperature increases, all the vitals, assessing the pupils, their level of consciousness. You're going to monitor neuros, all of their all of their reflexes, gag reflex, blink, swallowing, all of those. And if they have increased intracranial pressure, make sure you're putting them in a Trendelenburg position. Wilms tumor, I kind of started talking a little bit a minute ago, but that is typically found in child's kidneys at about 3 or 4 years. Parents or caregiver finds the bump around the waistband when they're bath time. It can affect one or both kidneys. And the kid can have some pain in the area. Typically, cancer doesn't cause pain until it gets big enough that it's pushing on surrounding organs. They're going to have some congenital testing, an abdominal CAT scan, MRI. They'll have a CBC, liver function test, UA, renal function test, And you are not going to palpate the tumor site. So, and you're going to educate that family. If they're coming in pressing on that patient's belly, going, look, look, look. Don't do that. That is actually can cause metastasis. So we don't want to do that. We're going to talk to the caregiver about clinical trials. We're going to make sure monitor their vital signs and blood pressures, because remember, your kidneys does affect blood pressure and have that whole renin-angiotensin system. You're going to assess the INO. Most of the time, kids will have chemo before the surgery. You're going to teach parents strict aseptic technique with a central line. They need to wear clothing with a loose waistband. You're going to make sure, again, telling the parents not to palpate that area, but they're going to avoid pushing, lifting when handling or bathing the child. And, you know, educate them that they can have side effects from the cancer treatment for several years. So just because they get done with it, it doesn't immediately go away. They do need to have genetic counseling, education on the side effects of the chemo, and surgery. So we kind of talked about this a minute ago, that hematopoietic stem cell transplant. This means that they are getting their own stem cells, but to begin with, you get a lethal dose of chemotherapy to kill the cancer cells and suppress the bone marrow production. And typically the indications are aplastic anemia, malignancy, but there are some non-malignant disorders such as sickle cell anemia and HIV. And so they can get it peripherally by IV. They are, when it's not coming from them though, when they're having stem cell transplants, because you can get stem cell transplants from others, you do need to make sure that they had a complex matching system so that to prevent graft versus host disease. That's why a lot of times when moms have babies now, they ask to bank the cord or baby teeth, things like that. And I think if the parent can afford that, it's very beneficial for things such as this. Most common complication of a transplant is when a donor is mismatched. So they really, it's no different than blood. They really have to do a good background. They have to really make sure that all of that goes. And then they are going to be, after they had that chemo, they will be getting medications so that they don't reject it as well. Come on, it's not doing. Okay, which type of lymphoma occurs to the peripheral lymph nodes and spreads to the tissue? Hodgkin's or non-Hodgkin's? B, non-Hodgkin's. It occurs in peripheral lymph nodes and spreads to tissues throughout the body. All right. I hope you guys have a wonderful day. If you have any questions, just let me know. Thank you.